Welcome to this tactical briefing on antimicrobial stewardship. Today, we move beyond the theoretical global mandates found in international manuals to address the frontline operational reality. For professionals in high-burden settings, the challenge isn't just knowing the guidelines, it's mastering the transition of these rules into a local context where resources are limited and resistance patterns are unique. Slide 2. The translation gap. There is a significant translation gap between what the CDC or WHO mandates and what a local ward can actually execute. While global frameworks assume leadership support and integrated EMRs, the local reality often involves intense administrative constraints and a heavy reliance on manual surveillance and physical justification forms. Success requires relying on champion physicians and clinical pharmacists to act as the primary engines of change when specialized infectious disease teams are unavailable. Slide 3. Localizing AWA-RE into the essential medicine list. The WHO AWA-RE classification is not just a list, it is a procurement and restriction engine for your facility. We must funnel antibiotics into 3 categories. Access, the first or second choice for common syndromes. Watch, monitored for restricted prescribing, and reserve, the last resort options for MDROs. By integrating these into your local formulary, you create cognitive forcing mechanisms, rules that make a clinician stop and think before deploying a reserve agent. Slide 4. The fallacy of copied guidelines. We must address the danger of dogmatically copying international guidelines. For example, while textbooks may suggest augmentin for anaerobic cover, in many high-burden settings, this is no longer a reality. Similarly, we must debunk myths about dosing. Regardless of renal insufficiency, a loading dose of 9 million units of colistin is non-negotiable. Local reality must always override international dogma. Slide 5. The local antibiogram. Data over dogma. The mandatory foundation for any empiric policy is the department-specific antibiogram. In our analysis of 1,708 isolates, we found that 78% of skin and soft tissue infections, SNSTIs, were gram-negative bacteria, a direct contradiction to standard assumptions that these are predominantly gram-positive. Furthermore, comparing pathogens like Pseudomonas and Acinetobacter reveals that susceptibility can vary wildly, requiring targeted local data for every empiric choice. Slide 6. The intervention spectrum. Stewardship requires moving from passive to active interventions. Passive methods like education and clinical guidelines are foundations, but they do not enforce change. To achieve results, we must deploy active frontline enforcement, such as pre-authorization protocols for high-end drugs and prospective audit with feedback, where the stewardship team actively reviews and suggests changes to prescriptions in real time. Slide 7. The critical juncture, the antibiotic timeout. The most crucial 48 to 72 hours of a patient's stay is the antibiotic timeout. At hour 0, we start empiric therapy. By hour 48, microbiology reports become available, and we must stop to reevaluate. This is the stop sign moment. Do we stop because the infection is inconsistent? Do we streamline or de-escalate based on AST results? Or do we optimize by switching from IV to PO? Slide 8. Case study, operationalizing de-escalation. Consider this County case study. A 54-year-old patient on broad-spectrum agents for suspected urosepsis. The 72-hour reveal, AST report, shows a carbapenem-resistant E. coli, coli M, that is unexpectedly sensitive to strong fosfomycin and nitrofurantoin. Stewardship action allows us to de-escalate from expensive broad-spectrum IV drugs to targeted, site-specific oral therapy, preserving the heavier agents for other patients. Slide 9. Navigating reserve agents, MDRO bloodstream infections. When managing MDR Klebsiella or other high-threat pathogens, dosing must be precise. We utilize decision nodes. If sensitive, tigecycline is a primary choice. However, if facing renal insufficiency and an MDRO requiring polymyxins, polymyxin B is often the safer choice over colistin. Remember, underdosing breeds further resistance. We must use surgical precision in these last resort calculations. Slide 10. The administrative lever, cognitive forcing. To protect our reserve agents, we use the strong, restricted antibiotic usage justification form. This is an administrative lever that forces the primary consultant to physically write down the clinical justification, such as meningitis, Acinetobacter baumannii. This creates a strong feedback loop, requiring a signature from an ID consultant or clinical pharmacist before the drug is finalized, ensuring accountability at the bedside. Slide 11. The systemic shield, AMS and IPC synergy. Finally, we must recognize that stewardship, managing the drug, is useless without infection prevention and control, managing the bug. An optimized antibiotic prescription is wasted if the MDRO is transmitted to the next bed through poor hand hygiene. As seen in MRSA clusters, a lack of standard precautions can negate the benefits of even the best targeted therapy. These are the two gears of a systemic shield. Slide 12. The implementation roadmap. We conclude with a clear implementation roadmap. Phase 1. Identify. Establish the core committee and integrate AWARE. Phase 2. Plan. Conduct a SWOT analysis based on local antibiograms. Phase 3. Perform. Deploy active interventions like timeouts and justification forms. Phase 4. Assess. Continuously measure process and outcome indicators to refine the tactical blueprint.